right, we're good to go. All right, thanks everybody for joining us today. We're going to talk about depression management using telehealth, similar format to what we had last week, just some Q&A with Dr. Arzubi. So please, put your information in chat as we start to talk about this very important and timely discussion. So all of our efforts are made to make this as timely as possible as it relates to telehealth. We know that those requirements are changing on a very regular basis and quickly these days. So we're trying to keep up as best we can. So please take that into consideration when you're watching the presentation today. A few logistics, your microphones have been muted and you will not be able to unmute them. If you do need to speak or would like to talk directly with Dr. Arzubi, we can elevate you to panelist and then you can speak. So just let us know that in the chat function. If you're not seeing the chat window, you may have to hover your mouse and over the 3 dots to get the chat box to show up. So please test that and do that. And so we'll have some good active discussion in the chat. The presentation will be recorded and sent out following our brief editing process, usually in a couple of days. Please share your experience and with the group so we can learn from you and to be kind to each other as we all are learning lots of things all the time, of course. Dr. Arzubi can definitely do more of an introduction, but he is located in Billings, Montana, so we're not going to hold that against him. And he's in private practice, has been providing telepsychiatry services for approximately 6 years. Sorry, I had to get that in there today.
It's all good. But you don't know if I'm in Billings because I could be anywhere right now. So
could be. But
that's right.
Yeah.
But I am in Billings, so yeah. So thanks so much, and thanks everybody for joining. So the focus today will be treatment of depression, and again, as with anything related to telemedicine and telepsychiatry, I think step one is always thinking about how to what we would do if we were doing this face to face, right? So step one is thinking about best practices, period. And so if you're considering, do you want to have a unified approach to treating depression, or at least get your team on the same page about how to manage depression? I think it's a great idea. It's clear it's hard to do because I know managing providers is difficult, period, and every provider thinks that they know best. So I get that. But I think if you can create an atmosphere or a team environment where people are open to kind of having discussion and maybe having an agreed upon sort of best practice within your team or within your clinic, I think makes a lot of sense. Because that way it doesn't feel like, because really the way it shouldn't be, and unfortunately mental health where we do this a lot, it shouldn't be you get a certain kind of treatment depending on who you go to. That's not okay. There should be agreed upon best practices. Certainly, and there is to a degree nationally, but certainly at least locally, it shouldn't. The treatment of depression shouldn't depend on who you see. Great. So how do you get there? Well, what I'd like to show you guys is sort of 2 resources that I use when I'm trying to come up with sort of best practices for, let's say, our practice or any practice or team I'm working with. And let me share, I'll go ahead and share my screen. So Mary, can you see this sort of chart? It says non-psychotic depression at the top.
Yep, we sure can.
Oh, great. Okay, wonderful. Thank you. So this right here, I got actually from Harvard. Let me go backwards here. So Harvard has this thing called the Psychopharmacology Algorithm Project at the Harvard Shore. Harvard Shore is one of their clinics. But I'll click on this. Oops. Hang on. Of course. Sorry. That was actually the paper that talks about it. So down here is a psychopharm algorithms. Here's the website, psychopharm.mobi. And you click here and you get this, and then you click on the menu and you go to algorithm flowcharts and you go to non-psychotic depression. And you'll see here it has treatment algorithms for different disorders. And some of the most common ones you'll see in primary care, right? You have ADHD, bipolar depression, bipolar mania, less common. But then you have generalized anxiety disorder, pretty common. Non-psychotic depression, which is basically unipolar depression. And then there's OCD, which might be less common. Then you have PTSD, more common. And then down here, social anxiety disorder. But again, for primary care practices who will see the most common things, you can look at those. And so if you go to non-psychotic depression, this right here is something that was published. They published sort of the written version of this in the Harvard Review of Psychiatry in 2019. This was updated less than a year ago. And this, for example, is an algorithm or guidelines really you can use to kind of unify your team around a best practice, right? So just real briefly, somebody presents with non-psychotic unipolar depression. Then it goes down here. Is this an inpatient with severe melancholic depression? If yes, then you consider ECT. But in the case of most of you'll be looking at right here where the answer is no. It's not someone with severe melancholic depression who's on an inpatient unit. And then it says try one of these: sertraline, escitalopram, or bupropion. So if you've not tried it, then it tells you to try it. If you have tried it but it's not, but it hasn't worked, then it suggests here your next switch. You could then switch from one of those three to, again, another one of those three. Or you can start thinking about other medications here, venlafaxine and mirtazapine. And then this goes on, and it gives you some recommendations in terms of how to augment. So you can, for example, augment with some over-the-counter supplements, light therapy, some second-generation antipsychotics, or add bupropion and mirtazapine. You can also add lithium or thyroid. But the point is, I don't want to get into the weeds about this, but the main thing is here, this at least gives you a menu about how to approach this that's evidence-based and evidence-driven. There is evidence out there to help us with decision-making. The other best resource that I use, and I'll click, let me see, does this, and Mary, forgive me, does this show, does this show the, this word here, nice? And the, yep. Okay, great. Okay, so this right here is another really great resource, which is it's a British resource called the National Institute for Health and Care Excellence. Quite honestly, the UK does a better job than the United States in publishing guidelines, and at least in psychiatry. This is a great resource, and you can find all kinds of treatment guidelines for psychiatric disorders. And I'd say that then after this, then Up to Date is another great resource. But this here is a free resource that similar to what I showed you before with the algorithms, will show you step by step how to assess for and treat depression, among other things. And then lastly, another resource. Here I'm going into Google, and so PALS. University of Washington guide. So the University of Washington in Seattle has what's called the Partnership Access Line, and this is like the MapNet line that was created here in Montana, which basically is again kind of a warm line for primary care to call and ask questions around treating mental health disorders in children. And I click here on care guides and resources. You can click on any one of these. They're all the same. So we can click on the one for Alaska, the Alaska Care Guide. And the Alaska Care Guide, just like the other ones, will have treatment guidelines for each one of these disorders in children. So again, obviously among those is depression. So again, what I'm trying to do is show you that there are resources out there that can help create some consistency and standardization around the treatment of depression and certainly other disorders. And then lastly, I think most of you know about the PHQ-9, rating scale, which again does a nice job in breaking out, from mild, moderate, moderately severe, and severe depression. And I think one of the things, again, we don't do enough in psychiatry that we need to be doing more of is really not only sort of the the screening, which I think primary care does a better job of, but then progress monitoring, and that is staying on top of those scores. And the reason I say that is that's really the best way to understand and know if we're actually making a difference, right? I think in mental health, we rely too much on patient self-report rather than using a standardized scale. And sometimes you can use other things as well, but I think a standardized scale is best, and that also forces us to be able to see if we're actually making progress and really hold ourselves accountable. And so, it kind of dovetails back to the idea of integrated behavioral health we were talking about last week, and beyond sort of the medication piece, because you'll see those treatment algorithms focus on the medication piece. A lot of this, especially the work that you can do in primary care through integrated behavioral health, is again sort of quote playing offense, right? Close quote, right? So again, playing offense is something we can do through integrated behavioral health, and really using the patient registry that we discussed last week to do patient outreach and reaching out to patients rather than waiting for them to come to us when they're decompensating. In terms of the psychotherapy that is recommended for depression, really there's CBT. Again, CBT can be used for lots of disorders, anxiety, depression, and it's always best to do that in combination with medications. I often get questions about, do you start medication right away when somebody's diagnosed with depression? What I would do is, if it's mild to moderate depression, start with psychotherapy first. And again, it doesn't have to be anything fancy. CBT or even online CBT is accessible. One of the things I want to be clear on too, I don't know if people know about, I think they've done a decent job publicizing, but let me just do one better for you, is Thrive for Montana. This is an online CBT. This is an online CBT program that I think there's still some free accounts that are available. So if you have patients that screen positive for depression and you're struggling to get them access to psychotherapy, have them go to thriveformontana.com and sign on for a CBT, an online CBT account, and they can get access to CBT online for free. And so that's and in addition to Thrive for Montana, Australia actually has a lot of CBT resources. They've done a better job than we have in terms of coming up with CBT tools for depression and making them widely available. But again, if possible, if all you have access to is medications and not a lot of access to therapy, I think using the online stuff can be very helpful, and actually more helpful than people think. So again, it's just another example of using telehealth and technology. In terms of the scales, I've been using the scales in a couple different ways over video. Is depending on what program you use. For example, what I will do, and actually I've been doing this with some of the patients recently here. I keep sharing and unsharing. I need to decide what I'm going to do here. So what I'll do is I'll use a PHQ-9 from this thing, MD Calc. So I click on this, and what I'll do is I'll actually do this with patients online. I will say, for example, here it says, how often have you been bothered by these things over the last 2 weeks? And I'll go through this with them. And so in the last 2 weeks, how many days have you had little interest or little pleasure in doing things? And the way I frame it to them, I say, would you say less than half the days or more than half the days? And then, or the other options are not at all or nearly every day. And so they might give me an answer and say, well, doc, it's been several days. So I'll click on that and move on. And how about feeling down, depressed, or hopeless? How often is that happening to you in the last 2 weeks? More than half the days. Okay, I'll click on that. And I keep going, and I go all the way down until the last question, and then here it sums it up automatically. And actually, I can make a note of that. So that's one way of doing it over telehealth. The other way you can do this is obviously you can set up Google Forms. Because G Suite Google is HIPAA compliant, so you can set up a Google form and have them fill out a PHQ-9 that way and just build it. Or obviously you can send them a PDF and then have them fill it out and send it back to you that way. But I found actually that using the PHQ-9, having the PHQ-9 there on and sharing it with them it works well, because I'm able to have a conversation about several of the the symptoms, the signs and symptoms as we go along. And if they give me an answer, I can ask them more questions about it. So with that, I will stop because I know it's, I should really only have gone for 10 minutes. I went a little longer, but just want to share a little bit. Again, the key piece to take away here is there are treatment guidelines that are evidence-based out there. And so I suggest, if you can, as much as possible, create a best practice for your clinic and encourage your team to follow it. Does it mean you're doing cookie cutter psychiatry? No, but at least you're following sort of best practices, and then you can kind of debate where to take what turn. And then again, using obviously using the forms, and there's several different ways that you can use the forms. And then obviously online treatment that again is online CBT that is sort of automated but has been shown to be useful, especially in very rural settings where there aren't a lot of therapists accessible. The technology is there, so let's use it. Let's use it. Let's not wait for the next pandemic to decide that it's a good idea to do this. So there you go.
Yeah, thank you. One other question. So Amber asked the group, and I wanted to pose this question to you as well. Do you have a standardized kind of way that you follow up with patients that you've put on a new depression medication? Like, what would you normally follow-up process be?
Sure. So I tend to make a follow-up appointment 1 or 2 weeks out. And again, I try to use the PHQ-9 every time, so we can have the conversation, say, wow, the score's dropped or the score's gone up, and then we can talk about which one of those parts of the score, which one of the elements has gotten worse or better and why. But also obviously to follow up for medication side effects. And there's some pretty common ones. In fact, there's one patient I recently started on Zoloft. He's a young adult. Started him on 50 milligrams of Zoloft. Turns out he's pretty sensitive to Zoloft. Made him feel pretty sick to his stomach. Dropped him to 25 milligrams. Had him stay there for about 10 days, then go back up to 50. So he was doing a lot better for about a week or two, then started having sexual side effects. And so, again, these things, side effects tend to be the issue that you need to kind of worry about with some of these basic antidepressants. But again, having at least during the first 2 months, checking in on patients every 2 to 4 weeks at the least, I think is effective. Other questions?
Okay, I don't see any more in the chat, and we'll grab some of that other information. So Amber, for a busy family practice, is it okay to have the staff schedule and complete the PHQ-9 and collect symptoms to report to the MD?
Oh, 100%. I mean, the more you can kind of delegate, obviously the better to make your practice more efficiently. So no question. So in that case, yes, the family practice, the family physician may not want to do kind of what I did and go over each one of the elements. Indeed, what you can do is have your staff help get the information to you, and then you can kind of highlight from the PHQ-9 what you think is either concerning or not, and discuss that. But absolutely.
Do you have a PHQ-9 in your EHR as well, or are you using this one and then going and just adding the information to the record? Sure.
So we are actually I found this really cool EHR. It's a mental health only EHR, so most of you probably won't use it, but it's called Valant, VALANT, and the Valant actually allows patients to fill out the PHQ-9. It uploads it in actually a pretty cool way. What it does, it takes the elements of the PHQ-9 and converts it into text into the actual note, which is hugely helpful for lots of different reasons, but not least of which is really documenting the details of each one of the elements. So the EHR we use for our telepsych practice is automatic. I use what I showed you guys, the MD Calc tool. I do that for the other thing I do is disability evaluations for veterans. And so there I don't use our EHR. I use a different system, but I use MD Calc for that. Okay. Other questions? Yeah.
Amber is collecting all the websites and putting them in chat.
Oh, nice.
All right.
Thanks, Amber.
All right, don't be shy, team.
And the other question I would ask is there anything you were hoping to get out of today that you didn't? Because if there are any gaps, I'm happy to throw something out there. Because I also want to make sure that whatever I'm presenting here is useful.
I mean, it's useful from our perspective, but we would need to hear from our attendees here. If there's anything else that they feel needs to be covered, or any future topics that you'd like us to chat with Dr. Arzubi about, you can certainly let us know. All of our resources are posted on our telehealth website, which is part of our main website. This is our last session that's been scheduled so far. So if there's something of interest, we're definitely interested in increasing behavioral health access across all of our states, and whatever we can do to help you all do that, whether it's with telehealth or additional resources, please let us know. We do have another question in chat. Thank you. How do you see a medical hospital's role in the integrated behavioral health model? Ooh, that's a good one.
So I guess one question to I think it's Tisa, is does that medical hospital have a primary care clinic? So that'll be my question. If they have a primary care clinic, then I think the answer I think it follows from kind of the conversation we had last week. If it has a primary care clinic, yes, perfect. So there's no reason the primary care clinic at the medical hospital can't or shouldn't be doing integrated behavioral health, right? Because you're going to have patients presenting with behavioral health issues to your primary care clinic, no question. So you might as well take advantage of the collaborative care model and create sort of this team-based care, because then you'll be able to be more efficient around the treatment, the assessment and treatment of the patients who are presenting in that way. And again, I think setting yourself up with maybe some basic treatment guidelines from some of these resources. So for example, if you have somebody who shows up with a high PHQ-9 score, likely depression, here's what your teams are going to do, right? So you're going to think about these three meds if it's moderate to severe, or you might recommend online CBT if you don't have access to a therapist, right? So again, there's a lot you can do even if you don't have access to sort of these specialized therapists. There are a lot of things that you can do without those things. But what's nice is the collaborative care model allows you to organize your efforts and really follow along to see if your efforts are making sense and if your efforts are actually making a difference. So I absolutely believe that the medical hospital, especially with the primary care clinic, plays an important role, especially for your community, in managing those things. And don't forget that, a lot of your folks who come in who have, for example, sleep apnea, diabetes, among other things, they're folks who are very vulnerable to having symptoms of depression. So the more you can kind of co-manage those things and do it in a way that's kind of comprehensive, I think the outcomes are proven to be better when you treat them together.
Great, good deal. Thanks for the question. There was another question about sharing the webinars with professors, and yeah, you can definitely share this information. We are federally funded, so part of that is that we get to give all the information back. It's pretty much public use. I was just wondering what school that was, so if Cindy wants to let us know, and if they have any questions, let us know about that as well. All right. Well, I am not seeing too much more come in, so we might be able to wrap it up. Again, we don't have any other scheduled sessions, so if there's something, a topic of interest to you, please let us know. And we hope that this has all been useful information about integrated behavioral health and depression management, albeit fast and furious type of sessions. We know that people's time is somewhat limited. Okay, so I'm not going to say that right. Nebraska University out of Owensboro, Kentucky. Well, there you go. We'll be interested to see what they have to say. Thank you. All right. Thanks, everybody. I don't know that we have anything else to discuss unless you have some other questions or anything else to add to wrap us up, Dr. Arzubi. Anything else?
No, I didn't think of anything brilliant to say at the end, so I got nothing. Thanks. I'm glad, again, I'm glad people I like doing these kind of bite-sized presentations, because at least it gives us the ability to kind of pull out 2 or 3 important topics. So I hope at least it gave you some tools to walk away with and think about to improve your practice. So thank you.
All right. Thank you all for your participation, and thank you, Dr. Arzubi, for taking time out of your day to provide us with this information.
My pleasure. Thank you, everyone.